And now, dear colleagues, please allow me to continue and pass the microphone to the Doctor of Medical Sciences, the Deputy Head Physician, Professor of St. Petersburg State Medical University, Professor V.Ratnikov, who is our Chief Specialist on radiodiagnostics. Most esteemed colleagues, please allow me to welcome you at this forum. It's very good that we have such lively communication between different specialists who work in this surgery, who work as internalists in hospitals. So I would like to say that one of the key responses that came from Professor Lodgy is that we should use the modalities that we have at the moment in our hands. Our hospital is a lucky one, as a wise and very up-to-date contemporary type of administration, organized our work in such a way that we have 2 MRIs. So one of them is 3 Tesla, 3 computer tomographs. Also, we have a C-arch for the radio manipulations in the GI tract, and also circular and convex sensors are available for us. So please put up your hands, those who have endoscopic ultrasound in your settings. 6 people. Who has MRIs? Not too many, but still a little bit many more. So we are moving towards the situation when every setting who deals with the biliary tract and the GI tract should have these options in their hands. And after such wonderful presentation from the surgery, I'm going to speak about the pancreatic gland, but not about the bile tract. But if we speak about the length of stump after cholecystectomy, for us to study the stump, of course, we should not be doing the endoscopic ultrasonography. You can see it on MRI within 4 seconds without any anesthesia to the patient, without any preparation. You just put the patient holds his or her breath, and in 4 seconds you can say whether there is any dilatation of the stump and what the length of the stump is. Sometimes there are certain findings which can be detected without MRI on EUS. But we should understand clearly that without clear understanding of the diagnostic potential of the CT, MRI, EUS, and ERCP, we are not full-fledged specialists in the diagnostic and treatment of this pathology. What unites all these people? They struggled, they had different potential, they had different economic opportunities, but all of them died. All of them died in the struggle with one lethal pathology, cancer of the pancreatic gland. You can see these people who passed away, the pathology that we're going to talk about at the moment. Okay, next slide, please, William. So, pancreatic cancer accounts for 3% of all the malignant malformations, 200,000 primary detected cases annually. It ranks 3rd in the GI cancers. Men suffer more often, and 95% of all the patients pass away. So it's one of the most lethal oncological tumors. And I should say that the risk of this type of cancer is 15-fold as high if there is a familial history of this disease. In the overall structure of malignant malformations, this type of cancer accounts for 2 to 7%. Adenocarcinoma is about 90% of all the pancreatic cancers, and the most frequent localization is the pancreatic head. We should say that in such country as Great Britain, pancreatic cancer is detected annually in 6,000 people. It rates 5 in the mortality structure. By 2011, Great Britain, in Great Britain, only 16% of patients survive within 1 year after the diagnosis. So just think about it: every sixth survives 1 year. So when it is diagnosed, only 15% of the patients have potentially resectable type of tumors, and after the diagnosis, the survival usually is not higher than 6 months. Whether it is a lethal disorder, yes, it is. And quite naturally, we should say that when a patient comes over to us, clinicians or radiation therapists or surgeons, they are already late 1.5 from 1.5 to 5 months, because mainly they come with jaundice. They try to get some treatment, and so the tumor growth from 2 to 5 centimeters happens within the period of from 3 to 12 months, depending on the age, of course, and clinical manifestations. You can see we have different level of people in the audience. We have resident doctors and experienced doctors. Most frequently, patients come with jaundice. And you can see that the reasons of jaundice can be different. It can be inflammatory disorders. It could be this or that type of reasons of bile tract dilatation also. And one of the most severe situations is associated with the tumors. And I would like to show you MRI cholangiopancreatography. This is a man 56 with some pain in epigastrium. MRI was performed, and according to MRI results, we cannot judge about this or that focal lesions, because you know that RCP doesn't give us a chance to have the tissue assessment. It just gives us the signal from the slow-moving liquids or fluids. But even here, we can say that there are classical manifestations in the area of the pancreatic head. This is the stump symptom, and also manifested pancreatic hypertension, the dilation of the bile ducts, and you can see very unpleasant-looking distal bile duct. So the patient was given recommendations, but unfortunately he went to a healer. For 3 months, he was doing virtually nothing, and if a radiation therapist has doubts about it, then you need to summon a patient in 2-3 months for a control MRI. You can see here already 4-stage degree with multiple metastases, and quite naturally jaundice, depending on the hospital, can be diagnosed, and the tumors can be diagnosed in different ways. And quite naturally, about 10 years ago, a brilliant Indian doctor, Kala, proposed a diagnostic algorithm, which in our institution is also implemented and which is still topical as of today. You can see that first and foremost, we can see CT with multi-phased contrast-enhanced. And this is the golden standard of radio diagnostics of tumors and malformations of the pancreatic gland. So I would like to remember this, because when tomorrow we speak about the biliary tract, the concept will be slightly different. If we speak about the imaging modalities, first of all, we speak about the gallbladder, and we can, of course, use the ultrasound MRI. First and foremost is MRCP, and the T2-weighted images allow us to differentiate the post-inflammatory processes in the biliary tract. Classical ultrasound, of course, is capable of demonstrating or detecting some extra liver duct disorders, and of course a very important place belongs to the EUS method, endoscopy ultrasound, with this or that treatment strategies. And of course we have a question of what kind of radiation modality to use, what kind of protocol to use. And when we have a colica, a biliary colic, a patient is usually referred to the MRI department, and if there are certain disputable situations, then we also perform ultrasound the next day. And the setting having 3 MRI and 2 CTs that run 24 hours is a normal algorithm at the moment. We should understand the optimal detection of the suspected pathology. We should think about the exposure. At the moment, this problem is very topical because we're trying to reduce the exposure, especially when we are performing diagnostics. And quite naturally, we should think about the primary and secondary lesions. If we speak about ultrasound, definitely there are a lot of benefits of this method. Every surgeon, and not saying a word about radiation therapists, definitely should have this method in hands. And you can see how you can get the image of the gallbladder, as well as assess all the vascular structures from the bile ducts. Also can detect the stone in the distal part of the bile duct, but nonetheless it is operator dependent. Also, you have this ultrasound window. Obese patients are quite problematic, meteorism, and certain, gray zones can occur. So, ultrasound allows us to decide whether it is a patient for the therapeutic department of a surgical department. The parenchymal jaundice should be studied. Even Stevie Wonder will see this or that manifestations or signs by means of contemporary diagnostic modalities. And first of all, we should understand what to do further on with the patient. If it is a tumor, whether the tumor should be resected or the patient should be referred to compassionate treatment. You should first of all get rid of the jaundice for at least to improve the quality of life for the 6 months or for the survival period. Then combination treatment or chemotherapy opportunities should be assessed. We use certain surgical techniques in our setting, which allow us to do different surgeries. The methods of radiodiagnostics are needed, first of all, to see the structural lesions, also to discuss the volume of surgery and the approach, and the post-operative follow-up. So first of all, we need to understand the tumor size and the localization. If it is a small tumor, if it doesn't compress the pancreatic duct, that doesn't invade into the pancreatic duct, then diagnosing it is almost impossible. And in this particular situation, if you can suspect such type of tumor, then EUS can be resorted to in order to verify the diagnosis. Of course, the presence of the cyst and correct diagnostic algorithm should be used. Of course, using ERCP for pancreatic and biliary pathology is not very contemporary, and it's not very correct. You can see Viktor Anatolievich here. And you can see that it's almost laparoscopic and endoscopically assisted surgery. This is our routine, our reality at the moment. And this is the multidisciplinary potential or the team approach to such patients. You can see how difficult it is to, first of all, understand the relation of the tumor to the superior mesenteric artery. And we have even the technique that allows us to do the prosthesis of this artery. And if the tumor ingrows into the mesentery, you can see how we can diagnose it by means of radiodiagnostics. And we do understand that by the data of international organizations and a number of authors, there are certain counterindications to surgery when we can compromise the quality of life. This is the remote metastasis, then involvement of these segments. Then if we speak about ERCP, this is unique method. This is the method which is very similar to the traditional X-ray. It will definitely accompany us always. And we have brilliant approaches when there is ERCP next door to MRI, for instance, and you can see how beautifully it is done. You can see the cholangiopancreatography here, or just the dilation of hepatic cholangiopancreatography. Apart from that, we can do stenting in the duodenum papilla, and you can also work in the pancreatic duct. You can combine different diagnostic modalities with stenting and with other methods which allow us to do photodynamic treatment. And our setting also has certain achievements here. When you introduce a drug, then there is a irradiation of a particular area. Thus, we improve the prognosis, and Lodge also said about it. This is high risk of complications because it is invasive procedure, and also it is radio exposure. This is something that accompanies ERCP. If we speak about MRI, then definitely you can see here the tumor of the pancreatic head. The worse the clinical manifestations are, the more beautiful picture on MRI you have. You can see here the tumor ingrowth into the pancreatic wall, enlarged gallbladder, and multiple secondary cholangioabscesses. What to do with such patient? Definitely, you will say that the biliary hypertension should be get rid of. Stenting cannot be considered because we have multiple changes of multiple alterations of the anatomy. Drainage should be done. Only this will allow the patient to survive with appropriate quality of life. This is another example which also tells you about the head, it shows you the tumor of the pancreatic head, and there are all the symptoms that also show it. You can see the narrowing of the distal part of the bile tract. You can see the secondary lesions and the secondary changes of the signal intensity on MRCP. And in the weighted dynamic images, where you can see less accumulation of the contrast, which tells you about the tumor. At the moment, the diagnostic potential of the MRI, we can use the diffusion weighted protocols or sequences, and if you have in your setting such diagnostic modalities, then you can see that this method somehow resembles radio isotopic. And if DVI protocol is not used, then please send your specialists to educational courses and the professional development courses, because the DVI methods, DWI methods, can reflect all the changes and lesions which could not be differentiated previously on MRI, and even dynamically contrasted MRI. You can see here the area of low intensity signal, and a very interesting observation that also verifies what I have said when the contrast is even not needed, because you can immediately say that in this area you have a malformation which most probably is a cancer. And even here you can see the mass effect, you can see the enlargement of the organ, atrophy of the adjacent organs, secondary hypertension. So you can use the DWI protocol, which allows you to improve the diagnostic potential of MRI. We can also differentiate the great papillary duodenum papilla tumor. Also, the pancreatic lymphoma can be visualized, and it's important for deep diagnostics. In our diagnostic potential as of today, we can also have a prima vista, which is paramagnetic, a classical paramagnetic, and that can accumulate in the unchanged tissue of the liver, which allows us not only to assess the liver structures itself, but also functionally to assess the biliary tract. It resembles us of the classical cholecystography. Doctors who have relevant practical experience, they remember these methods in the X-ray rooms. At the moment, the constant matter allows us to assess the dynamics of the biliary tract, and allows us also to assess the time of contrast matter in the duodenum and assess the lesions that can be classified as types of sphincter dysfunction. If we speak about the pancreatic cancer, then we should understand that the inclusion of the patient of chemotherapeutic protocols should definitely be grounded on the assessment of the secondary lesions or secondary changes. You can see here that the organ is changed, there is ascites, but when we use prima vista specific contrast matter, we can diagnose the lesions up to 2 millimeters. Not for a specialist or in chemotherapy, it is very important because it can allow us to judge whether the number of lesions grow or is reduced, whether there is any prognosis which is positive or not. Another example, very high biliary hypertension doesn't allow us to use the contrast matter. There are certain limitations in very high hyperbilirubinemia. It doesn't work. And MRI is a very informative method, both for the biliary tract and for the pancreatic gland. It's very informative, but there are artifacts and insignificant slices led us to the following. CT characteristics make the basis of the tumor diagnostics, as well as detecting the resectability of the adenocarcinoma. And this is really so because the thickness of the slices and isotopic scanning allows us very good resolution, which gives very good diagnostic information. This is CT, MDCT, which allows us, after the post-processing, to detect the condition of the liver ducts. Now, the contemporary CT results, you can see how good they are. And before surgery, you definitely should assess how the tumor is, what is the relationship of the tumor with the So in a number of cases when we cannot visualize certain structures, you can give double contrast. And you can see the endoscopic ultrasound here, EUS. If the CT and MRI doesn't verify the diagnosis, then EUS also can be applied with very good diagnostic value. Now, in CT, you have the common liver artery stenosis, but the diagnosis is quite different on MRI. Also, contrast enhanced CT, you can see the head here, but you do not see the malformation. But if you use magnifodipir on MRI, it gives us a chance to contrast the tumor of the pancreatic head. So MSCT is the basic modality for diagnostics, but nonetheless you can see that every treatment or every diagnostic modality has its own plus and negative points, so the combination is our choice. PET. You will ask me whether it is important or not. So 10 years ago, PET was considered to be a breakthrough. At the moment, we understand that there is certain place for applying PET when you need clearly to differentiate the activity of a drug, if there is hyperfixation or not. You can see how brilliantly you can differentiate the lesion in PET-CT. You can see metastasis and of the melanoma into the pancreas. This is metastasis of adenocarcinoma of the liver into the pancreas. And you can see that something that was first detected in MRI by means of PET, it can be classified as malignant. But there are at the moment studies in order to detect the traces that would be pancreas specific, and certain traces give us an opportunity to get very specific information in every 4 patients, and it's quite important. When we come across the already operated patients with very changed or altered anatomy, we understand very well that in this particular changed anatomy, it's almost important to understand whether normal is and whether relapses, and then we use PET. You can see a very small resolution in the matrix, but nonetheless it gives us a chance to see that the fluorodeoxyglucose is captured. PET is diff diagnostics, and also AIP diagnostics, and cyst malformations, of course. Then EUS. EUS is something that we can speak for hours about. And EUS is something that we're discussing at the moment. This is our surgery and our sensors. You can see how well the anatomy can be seen in EUS. You can see the audio sphincter in its open and close mode, and this is something that we have seen from the operating room. And we should definitely say that the imaging, how well we can see the pancreatic head or the liver, definitely is great and brilliant. And we consider that in very difficult situations when you cannot differentiate chronic pancreatitis of the pseudotumor, definitely EUS should be resorted to. That allows you not only to assess but also to obtain a biopsy of the tissue and the cysts. Diagnostic science is something that you are going to discuss further on. Evgeny Solonitsyn will talk about this in detail. Solid malformations. Why do we need EUS here? In order to differentiate, to stage, and to get histological verification further on in order to determine the treatment strategies. Diff diagnostics of the fluid and cystic malformations, you can see a good use of the Dopplers. Diff diagnostics of malformations which are difficult to diagnose by MRI, so EUS can be also of help here. This is the assess of the intraductal small tumors, which are very difficult to diagnose on MRI as well. This is deep diagnostics of changes and lesions that resemble something on MRI, and imaging of EUS by EUS. You can see how well the intraductal tumor can be visualized. And you can see the data. EUS gives us a great opportunity of assessing the invasion. Now, clinical application of EUS can be used in the preoperative period in order to understand whether the tumor is resectable or not. Then fine needle biopsy, fine needle aspiration is something that we use quite a lot. In all patients with a suspicion of tumor, we take samples for oncomarkers, immunohistochemistry. So this is something that we currently are working on. We use the EUS for draining of this or that processes in this area. And also, it's very important to say that endoscopic ultrasound gives us great opportunity because it's also a treatment modality. But the experience that we're accumulating at the moment leads us to the necessity to share our experience. You can see how difficult the diagnostic potential of the radiodiagnostic is in the primary tumors. First of all, it's CT. Then MRI allows us to diagnose dilated ducts, but then the EUS is the final modality before you take decision about surgery. And once again, what is the success? What is the success grounded on? First of all, it's a multidisciplinary approach. We definitely have continuity between internalists, GIs, and other specialists, and this allows us definitely to have good results in diagnostics and treatment of this very complicated and not very favorable prognostically patients. I would like to say that 3 weeks ago, we had a patient in who we 7 years ago performed pancreatic duodenal resection, and he survived 7 years. So the statistics should not stop us and should not make us pessimistic. Thank you. Dear colleagues, you have an opportunity to ask questions to Vyacheslav Albertovich. You can see that he has MRI, CT, and ultrasound in his hands, and he understands everything about the diagnostic procedures, and he can compare different modalities. So please, your questions. We have time for discussion. If there are no questions, then we can discuss it backstage. Just one question. Could you tell me, we are talking about ultrasound as a physical grounds, a physical basis. At the moment, so I would like to say that ultrasound, whether it is EUS or transcutaneous, it has different physical basis, and the expert investigation or examination can surpass other diagnostic imaging modalities, because ultrasound gives us better assessment of the pancreatic structures. That's why we use an expert examination with a surgeon. We use transcutaneous ultrasound, and in tumors over 3 centimeters, the main questions of surgery can be done without any radio exposure. I would not agree with that. And I consider that if you do it because there are no other opportunities in your setting, so I can praise you for that. But if you have MRI and CT, you cannot refuse a patient these opportunities.